Namaste Vidya, Sada Khush Raho. Myself Dr. HEMANT Vyas, Associate Professor and Head of Department of Surgery, Faculty of Homeopathic Science, Jyoti Vidyapeeth Women's University, Jaipur. Today we will discuss perforated peptic ulcer. Introduction. It is more common in males and the ratio is 8 to 10 men to 1 woman in India. Anterior duodenal ulcer perforates and posterior duodenal ulcer bleeds. An ulcer on the posterior wall of the stomach can perforate into the lesser sac. Usually patient with a long history of peptic ulcer suddenly complain of feeling something that has given way in their abdomen. It may be precipitated by excessive smoking, alcohol, drugs, etc. and rarely a silent ulcer can also perforate, especially those patients treated with cortisone. Patient taking NSAIDs, that is non-steroidal anti-inflammatory drugs, often elderly, can present less dramatically. Two factors are associated with most perforated peptic ulcer: chronic use of NSAIDs and Helicobacter pylori infection. Patient with Helicobacter pylori infection and perforated peptic ulcer tend to be younger with a male predominance and more prolonged period of dyspepsia. However, NSAIDs category of patients are elderly with equal proportion of both sexes being affected. Perforated peptic ulcer have a mortality rate of 5 to 10%, and perforated gastric ulcer in the elderly have 20 to 30% mortality rate. Golden time to operate is within 6 hours. Now let's see what are the stages of duodenal ulcer perforation. First stage is a stage of chemical peritonitis. Immediately after perforation, gastric and duodenal content leak into the peritoneal cavity and produce severe agonizing pain in the right hypochondrium. It is mainly HCl which produce pain. There may be an episode of coffee ground vomitus followed by melena afterwards. The pulse rate increases, the patient is pale and anxious, and blood pressure may be normal in the initial few hours. Per abdomen, there is guarding and rigidity of the abdominal wall. Rebound tenderness is present all over the abdomen. This sign is called as Blumberg sign. On percussion, liver dullness is obliterated because of collection of free air, that is gas, under the right dome of diaphragm. This stage is seen from about 2 to 4 hours from the time of perforation. Bowel sounds are usually absent. Stage of reaction is the second stage. The peritoneum react to the chemical irritant by secreting peritoneal fluid. As a result of this, HCl and bile are diluted by the peritoneal secretions and resulting in an improvement of symptoms. Hence it is called as stage of dilution of stage of illusion. This stage lasts for 3 to 6 hours. However, the signs are worse. Pulse is feeble, more than 120 per minute. Hypotension persists. Evidence of dehydration due to loss of fluid into peritoneal cavity. Shifting dullness is present. Abdominal distension is due to fluid and paralytic ileus. Bowel sound are absent. Guarding and rigidity are worsened. Third stage is of bacterial peritonitis. The peritoneal content get contaminated with gram-negative organisms, resulting in bacterial peritonitis. The patient becomes severely ill, dehydrated, toxic, with drawn-in cheeks. The tongue is dry and coated, but with bright eyes. This is called as Hippocratic facies. Features of hypovolemic and septic shock, such as a feeble 3D pulse, cold peripheries, shallow respiration, high grade fever, and persistent hypotension are present. Cross abdominal distension, guarding, rigidity, abdominal tenderness all over suggest generalized peritonitis. Investigation of perforated duodenal ulcer. Complete blood picture and electrolyte study. Plain X-ray chest or abdomen in erect position shows collection of free gas under the right dome of diaphragm. In majority of cases, if patient is unable to stand, left lateral decubitus films are taken. When in doubt, request a CT scan with contrast which can demonstrate pneumoperitoneum, fluid in the abdomen site of perforation, and some surprises also. air under diaphragm. Here we can see air under, this is right dome of diaphragm, this is left dome of diaphragm. Now treatment includes aspiration of stomach content by Ryle's tube to reduce further contamination and to decrease biliary and pancreatic juice. Blood grouping and cross matching may be necessary for surgery. Charts must be prepared: temperature, pulse, BP, respiration, urinary output. This chart should be prepared. Drugs injection: ampicillin 500 mg intravenous stat and 6th hourly against gram positive organism. Injection gentamicin, injection metronidazole and cephalosporins must be given to the patient. Exploratory laparotomy is done through a midline incision. The perforations is identified and closed with interrupted non-absorbable silk sutures, which is strengthened by placement of omentum. Peritoneal toilet wash is given to avoid residual abscess. Abdomen is closed with a drain which is removed after 3 to 5 days. It is a large gastric ulcer. It is better to do a gastrectomy if condition of the patient permits. Then fluids are given pre-operatively to treat dehydration, post-operatively for 3 to 4 days till the paralytic ileus settles down. Soft abdomen and bowel sounds must be present. So that's it from the presentation. This session is powered by digital version 2.0 Jyoti VIDYAPEETH. Hope you are satisfied with this digital session. If you have any query, please mention in comment box. I will try to resolve it. Thank you very much.